Hi,
Hi,
Tara.
Susan.
I was just gonna text you, but I was like, maybe she'll get on a little early.
Yeah, I saw
Um,
you popped on, so I figured I would. It looks like
yes,
it's set to be recorded.
yes. I was just gonna say, I just talked to Julia, and she said that Kristen texted her and said it was all set to be recorded. But if you don't mind staying on the line, and Julia's, we should figure out who's going to record it if we don't, if it doesn't
Yeah,
record
I'm
automatically.
happy. Yep, I'm happy to be
Here's
here
Julia.
for any and
Julia,
everything you need.
who wants to, like, if it doesn't record,
It's already
somebody has to
recording.
give me the heads up
It's
and
re-
I can record it, or,
It's recording right now. It's
oh,
already recording. So we can
okay,
cut the
that's
video
great.
later, but it's automatic, so we're good.
Okay, we can
Perfection.
play
Go,
back
Kristen.
Susan's distress over it being recorded or not. Great.
She's so good.
She's so good.
I
You
just
guys are
turned
all
off
so
the
good. Oh my
transcribing.
God. Marissa, I
Hi.
right near your house?
Yes. Next
Where is
time
your
you
house?
go to
It's not right next to Bear Swamp, is it?
no,
Okay,
it's on
'cause
North
there's a
Bear
new-
Swamp.
Oh.
So you go back to the Story Road, intersection where Rumney is, and you go up Story Road, but it's like only like 5 minutes from there. So
Oh my
tell me
God.
next time you're going to.
I will.
I forgot that you go all the way out to Bear Swamp
I
Veterinary. Like that's so
do,
far
yeah.
for you.
So he'll
Well,
go
if
to
you're going
Rumney
again, tell me.
School. Does he go to
What's
Rumney
that?
now? Does Asher go to
He
Rumney?
could for preschool. That's where he'll go for kindergarten.
It's such a cute little
He goes
school.
to Turtle Island.
Okay. Oh yeah.
Yeah,
Right.
that's his kindergarten. Yeah, no, my house is like 5 minutes from there. So if I was home, I'm not even there today, so it
Yeah.
wouldn't work. But if you're going to the vet, tell me.
Yeah, I will. Well, hopefully
just
I
stop
won't
by.
be soon. But the verdict on Bo is he's old, and he doesn't
Yeah.
have his kidneys are slowing down. He's fine though. He's not like if he gets worse, he can
He's
go on a
just old.
special diet. But he's old.
Yeah, that's Cloudy.
happens.
Cloudy's old too.
Yeah. How old is Cloudy?
Well, we don't know exactly because he was an adult cat, but we've had him for 14 years.
Oh my God. Wow.
Yeah, so
he
he
could be
15 or 16 or yeah, so he's pretty old. I mean,
You've
cats
had
can
him. I
be,
was gonna say,
you know,
ever since I've
18,
known you,
19,
you've
20.
had him, right?
Oh no, we've had him for
That's
14 years, and he
wow.
was an adult. I mean, he was a young adult when we adopted
Did you
him, but he
adopt
wasn't
him
a kitten.
from like a shelter?
Yeah, from the Chittenden County Humane Society,
Oh,
which was my first job when I moved to Vermont.
I didn't know that.
Yeah, that was the first job I got. I took care of the
Wow.
animal. And then I left there to go to Planned Parenthood, but I
Yeah,
did.
yeah.
I took care of the animals. So,
You
wow.
took care of people there too. You're just taking care of everyone. Now you're taking care of Vermonters.
Yeah, that was my
Great.
journey.
All right, I should pull up the agenda. I reviewed it yesterday though, but I'll do it again. And Marissa, I'm going to turn it over to you to introduce Bruce. Or
Yes, I have a brief
they can introduce
introduction.
themselves. Yeah, but like
Yeah,
you
I'm
can-
going to do the
whatever
introductory
you wanna do.
slides, and they can introduce themselves. But I'll briefly introduce them and
Okay,
remind
and
everybody
are
that
you-
they've heard from them before.
Yeah, are
in
you doing the
September.
slides or are they, or what should we do about that?
I'll do them. I'll
Okay.
project them.
You know what might be nice is Tara, can you project the agenda when after Bruce and Elizabeth go, like when we go to the next section when I'm asking the advisory to look at the upcoming events? You know how the second, oh, and did we fix that date? Just realized that. Let's see.
I'm gonna have to check to see if I even have the agenda.
Okay,
Bear
I'm
with me
gonna
for a
send it
second
to
here.
you right now.
Okay.
Let's see. I just accessed it through the advisory. I can actually just tell them it's a type that we're not a typo, that we're gonna change the date on that. But I'll show it to you. I'll send it to you now. I think you'd have to go into the website to fix that, and somebody should fix it because it's the wrong date now.
Okay, yeah, I can take care of that if. I have
Okay,
the time.
I'm gonna, let me share this with you now, and then I'll tell you exactly what the issue is. And then I think that should work.
Okay, I just got your email. Oh,
So if you look at, I could share my screen too, but if you look at the, under item number 3, overview of upcoming GMCV activities, it says February 16th, hospital budget overview, and we switched that to February 21st.
21st. Okay. Do we know where this Word document is?
I don't,
Jen?
Tara, why don't you and I coordinate? I'll chat with you. I think I
Okay,
probably can figure out where it is.
perfect.
and-
Okay.
and it's
And
okay,
then-
I'll tell them if it doesn't get done before we get to it. They've already seen this agenda, so I want to let them know that the date has changed, so I will make sure. And if I forget, you guys, just
Mhm.
chime in and remind me.
Okay.
Thank you. Oh, you're on mute,
Hey,
Bruce.
Bruce.
Well, mute is a problem. How are you ladies?
Very well. How are you feeling? How's your hand?
I'm doing all right. Hands better. Working away. Got a visit Wednesday to Brattleboro
Great.
and have several others lined up. I think I sent Melinda the table that has
Hey, Marissa.
has it in. We're lining up more.
You mean Marissa? I call everyone the wrong name. You said Melinda.
Oh, I'm sorry,
That's a
Marissa.
nice name too, but Marissa.
I'm
no,
looking at the Melamed and I'm
I know.
just going right on. I'm sorry.
No, we have a lot of staff that at one point we had like 3 Sarahs, and
Wow.
then everybody else's name started with an M, so it was a challenge.
Yep.
And as I get older, I call everyone knows this. I call everyone the wrong name.
Well, you don't have the problem I've got. I'm probably twice your age.
Oh, I don't know
So,
about that. Hey, every day is a gift. That's what I say.
well, that's right. My dad used to say every day you wake up looking down on the daisies, you're in good shape.
That's what I say.
GB tag.
So we got, I don't know if they told you, but I did get the data from VAS on the
Okay.
avoidable days, the
Okay.
boarding days and avoidable days, and
Great.
their calculation of avoidable ED visits is 30% or a little more for everybody.
You know
I mean,
what? I
it's
think we're on a public meeting now. I mean, this is all going to be public anyway, but I just wanted to let you know we have other people on.
that's fine.
Yeah.
Yeah,
Yeah,
that's
I mean,
fine. I'm
the
gonna
people that would be having the data anyway.
talk about a
Oh,
little of
Kathy
it.
Mahoney, I haven't seen you in ages. Hi. Yeah.
Owen,
You're
how are
back.
you?
Yeah.
I'm well, Bruce. Nice to see you. How are you?
Good to see you. Doing well, thank you.
Wise. Good.
Working hard. Yep.
Yeah.
Like we're filling out, you're going to get a few more comments since we get more advisory committee members to join. It's just 201, so that takes a little bit to get online.
You're breaking up a little, Susan.
Really? Huh.
Well, it's like
Should I call
robotic.
back in? Let me call right back in. Might be my connection. I'm gonna hang up and call in. Is it for everyone? Am I
think, Bruce,
breaking
we are
up?
expecting Elizabeth, right?
You are? Okay, I'm gonna call back in.
I say you're nice and clear now, Susan. Oh, too late.
I've noticed that with her connection sometimes goes in and out. And okay, there's Elizabeth. We'll wait for Susan to come back in.
How is that? Any better? Better? Okay,
Yes.
great.
Sounds clear.
Crackling is not fun, so. Okay, I see. Look at my list here, folks. I see we have our presenters, so that's wonderful. And we have several of our advisory members on, so we did hear from a couple of folks that they weren't able to make today because of travel commitments, but why don't we go ahead and get started and welcome everybody to today's General Advisory Committee meeting. We have a really nice, for policy wonks and healthcare wonks like all of you, I think a really interesting presentation that you'll see from our consultants from Oliver Wyman, who we've been working with for quite a while now on the hospital and healthcare sustainability work. And they're going to present some of the data that they learned about and some of the results of their first round of community engagement. And our staff will also share some of their perspectives with you. I see we are getting some more folks from the advisory, so that's fantastic. We're joined today by several members of our board as well. Owen Foster, Chair Foster, Robin Lunge, board member, and Jessica Holmes, board member. And then, as I said, a couple of our staff will be presenting on the hospital sustainability work. So with that, I am going to turn it right over to Marissa Melamed, who is the project director for the Act 167 hospital sustainability work. And she's going to tee off our presentation from the Oliver Wyman folks. So I'll turn it over to you, Marissa.
Hi, everyone. Good afternoon. Happy to be here. Marissa Melamed. I'm going to bring up the slides. So just give me a minute while I set that up. I'm going to do just a couple quick introductory slides on where we're at in the process, then I'll turn it over to the Oliver Wyman team.
Marissa, while you're pulling up the slides, I do want to remind the advisory members we did send out an agenda with a couple of questions for you to think about as we're going through this presentation.
Yes.
So, and of course, all questions are welcome. Marissa and the team, Elizabeth and Bruce, would you want us to hold questions till the end, or would you like members to interrupt with questions? Your preference.
No, I think interrupting with questions is fine. We'll shorten things as we need to stay to the hour.
Great, thank you. Okay, I'll turn it back to you, Marissa. Sorry for that interruption.
Oh, no, great. That's great. I have those questions too on a slide so that people can think about them as we go through. But first, I want to do a quick introduction. We're really excited about where we are in this project. We have a great team, both at the board and with Oliver Wyman working on this work. This is our second time addressing this committee. The project has hit its phase 1 deadline. So we're going to talk to you about kind of where we've been. Bruce and Elizabeth will go into detail on that, and I'll kind of give you the overview. We're pretty excited about the statewide coverage and engagement that we've had so far. So as Susan said, in my role at the Green Mountain Care Board, I serve as the project director for the Act 167 community engagement work. As I think people are familiar with, Act 167, Sections 1 to 2 encompasses a large body of work that's led by both the Green Mountain Care Board and our partners at AHS. So there are other streams of work going on simultaneously on the subsequent all-payer model agreement, the development of value-based payment models and hospital global budget development, and the evolving Green Mountain Care Board regulatory process for hospital budget review. And then this piece of work, which is the statewide community engagement to support hospital transformation. So I'm going to reintroduce you to the Oliver Wyman principals that we've hired to complete this work. So we thank all of you who were able to meet with Bruce and Elizabeth already. They addressed this committee in September while we were developing the engagement plan and the roadmap for this project. And so it's great to be back here for this update. Again, Dr. Bruce Hamery is a clinician leader and facilitator with over 50 years of experience, specifically executive leadership and healthcare systems and rural hospitals. He's done work in Vermont before, so he has great familiarity with our system and lives nearby in central Massachusetts. And then he brought on Elizabeth Sutherland, who has expertise in examining health disparity and overcoming health equity barriers. I'll let them introduce themselves further if needed during their talking points. So here's an overview of the progress and timeline where we are now. So last time we addressed this committee, we were in that first box there, engagement plan development, which we started back in August. We spent several months developing the engagement plan. And then in October into November, the project moved into its phase round 1 meetings, which were extensive and statewide series of listening sessions targeted at community members at large, providers, and members of the diverse populations. Those meetings ran October 24th through November 21st, and we're going to show you numbers on the next slide about what the participation looks like there. The current stage that we're in is a data synthesis and analysis stage where the OW team is using data collected from the listening sessions combined with relevant analysis of health system claims and hospital discharge data to inform preliminary options and recommendations for the hospitals. And we're working out timing around the round 2 community and hospital meetings, which will be in spring or late spring 2024. But the focus of today's meeting is on findings from that round 1 meeting, so they can talk to you about what was heard and a little bit about plans going forward. So we're really pleased with the numbers of people and organizations that were engaged in the first round of meetings. It was over 1,800 participants across all stakeholder types and meetings. There was an average of 52 participants at the community meetings, including the statewide meetings. Meetings were held in all 14 hospital service areas, 2 meetings in each, 1 for community members, 1 for the provider community. There were also 4 statewide meetings at different times for folks who couldn't attend in their region. On our list of organizations contacted and outreach to, we had over 100 that we were in touch with. We received over 93 public comments as well that were reviewed. And then there's more specific numbers here on the right around the different groups that are engaged with, and they include hospital leadership and boards. So there are separate meetings with each hospital leadership and with their boards. There is a list of diverse population groups that was that Elizabeth will talk more about, that was created using populations served by organizations receiving health equity grants through the Vermont Department of Health. At least that's how we started generating that list. And then it was built out with community input. We spoke with state partners, which includes Agency of Human Services and departments, Department of Health, Department of Mental Health, Vermont Emergency Management Office, State Office of Rural Health, many community leader groups, including unions, federations, associations, business organizations, the Vermont Developmental Disabilities Council. We were in close communication and contact with input from the healthcare advocate on both the engagement plan and on receiving their input. And then you can see the numbers there on attendees at the community meetings, provider meetings, as well as some individual interviews and sessions. So that gives you an idea of the broad swath of Vermonters and those representing Vermonters that the team spoke with. Bruce and Elizabeth facilitated each and every one of these meetings. They were attended by Green Mountain Care Board members who listened, as well as staff from the Green Mountain Care Board. The Office of the Healthcare Advocate attended all, if not most, of the meetings, and many other providers, organizations attended as well for both listening and providing input. These are the discussion questions that are pretty broad that we sent out ahead of time, but to think about as we go and ask questions. What is one or more takeaways that stand out for you? What stands out for you the most? And what is the best format for sharing information with the public as we move forward in this process? So we can think about those, bring them back, and it's possible Bruce or Elizabeth or board members might pose additional questions that you can think about as you hear this information. So with that, I'm going to turn it over to Dr. Bruce Amory to go through their findings.
Thank you very much, Marissa. Before I start, let me just thank the many people, both citizens and providers and healthcare folk and their boards who participated very actively and very candidly in this process. I also need to thank the various state agencies. They've been very helpful. And I would note the Vermont Association of Hospitals and Health Systems has also been very helpful in getting data from the hospitals, and we'll talk just a very little bit about that. I'm going to review that with them this Thursday. So we could have the next slide, please, Marissa. Okay, so we're going to basically go through this agenda. The goals of Act 161, we're going to go very quickly because you're all aware of that. And we're going to really spend time on the preliminary findings from the interviews and listening sessions. These were extremely helpful. And what I'm going to do with that is take the 9 elements of community essential health services in a community and go one by one through those. Elizabeth is going to do the equity piece of this, and she really led it and was in all of those meetings. And then we'll talk for a couple minutes about work in progress and where we're going for the last part of the work. Next slide. Okay. So this is what we were supposed to do, have a process that's data informed. And we've reviewed a lot of data and a lot of existing reports, both from state commissions and other consultants, patient focused and community inclusive. And I think you've heard from Marissa about that. Our outputs are to help hospitals reduce inefficiency and constrain their further growth in costs. Improve population health outcomes, reduce health inequities, and increase access to essential services. And I said we're going to go through those. Next slide. Okay, so first element's primary care. And you'll note that each of these slides starts with a couple of quotes from some of our listening sessions. The 2 relevant ones here are, it's taken me 18 months to find another physician, and another person that said nobody's taken new patients, and there's a 1-year waiting list for new patients from the physician office that I talked to. So you're well aware there's a shortage of both primary and specialty physicians. due to an aging group of practitioners who are retiring and burnout from a number of issues, COVID certainly, but also, as you'll see, a lot of frustration with electronic health records and pre-certs and pre-authorizations and paperwork generally. And there is moral injury to many of the providers because they feel they are unable to obtain help for their patients, whether that's a transfer to a more appropriate level of care or the ability to get a referral to a needed specialist and similar things. Unfortunately, there is also a shortage of advanced practice clinicians. No in-state training programs for advanced practice RNs, nurse practitioners, or PAs. The nursing school at UVM does have a training program for doctors of nursing practice. There is an accelerated program as part of that, but it still requires pretty lengthy training, up to 5 years, to really get someone certified as, let's say, a nurse practitioner or someone with appropriate clinical expertise in a given area. Part of this whole problem, just to produce medical assistants, licensed practical nurses, RNs, and so forth, is that there is a shortage of both instructors and sites for student clinical rotations. The other thing that really came out is that there is, I think, some interesting information that administrative complexity for the physicians takes up a substantial part of their day that would otherwise be devoted to patient care. So one physician said, I spend at least 2 hours a day on the phone for pre-certification and prior authorization. This was repeated by a number of others. Another physician said, boy, just to handle all this stuff, billing, the pre-certs, the back and forth with the specialists, I've had to hire 4 support staff for each clinician. So the practice costs and the administrative complexity are severe. Just to take an example, if you figure a 35-hour work week in patient care for a physician, and 2 hours a day is devoted to paperwork, if those hours could be reduced, a physician could see as many as another 740 patient visits a year, which is not small. There is difficulty recruiting medical professionals of all kinds, including laboratory technicians, radiology technicians, nurses, physicians, and others. The thing that was most commonly cited was a lack of housing. And there have been hospitals that have reported, gee, we signed a doc, they came to work, they were with us 3 months or 6 months, living in a hotel, and they gave up and went elsewhere. So that's a big problem. They've also cited, you're trying to recruit folks who are reasonably young, have a family, there may not be local childcare, they may have an elderly parent that they don't feel support is adequate for. And some comments, not yet verified, that pay scales are low relative to what people can get elsewhere. Next slide. Okay, access to essential health services, psychiatric and substance use treatment. One patient said, boy, psych referrals are controversial and difficult to obtain. They would show up in an emergency room with a diagnosis of a psychiatric need, and they didn't have resources, for example, PTSD. A mental health advocate said, the ER is not a place for mental health care, and people give up if you go to the ED and docs aren't trained. As you're all well aware, there is a shortage of psychiatrists and mental health professionals. Part of that may be had been cited people leaving the state. But the other thing that came up repeatedly is that the Licensing Bureau for Mental Health Professionals has imposed some rules that make it difficult, even for people with prior training, 3 or more years of experience in another state, to get a license to practice. And some individuals with whom we spoke said, gee, I was going to have to go get another master's degree. A state commission on healthcare workforce a couple of years ago noted this, and I think the mental health group was given 5 years to fix this. And I will just say flatly, that's way too long. This can be fixed in 3 months. Shortage of mental health beds for acute and chronic needs. Currently 194 beds for adults, 23 beds for children. There are 12 new beds being added. And one state official said, gee, prior to the pandemic, this would have been enough. Don't think this meets the need anymore. The national standard or national number cited is about 50 beds per 100,000 people. And so you can compare. There is also a shortage of intensive outpatient services and daycare services for the people suffering from mental health and substance abuse. And certainly intensive outpatient, were it readily available, could and should decrease the need for inpatient beds. There's a lack of group housing and difficulty finding appropriate transport for suicidal patients. You're aware the legislature passed a law a couple of years ago about restraints that people could not be placed in a police car to be taken to a mental health facility, a suicidal patient. And so right now they are transferred by emergency ambulance, which are in short supply. And so, a means of transport that doesn't require a certified EMT and a paramedic would be helpful. There's also generally a lack of appropriate facilities in the emergency room for suicidal and other acutely ill psychiatric patients. Some hospitals are spending several $million to add these facilities. And this need is a substantial contributor to the need to board patients, keep them in the ED pending transfer. Next slide. Okay, emergency and observation services. One of the ED directors and a number of others commented that many patients that are labeled avoidable actually must be seen. They come from skilled nursing facilities, police, social services, and they have nowhere else to go. And again, that is a huge issue. And I have just about a week ago now, gotten data submitted by each hospital down to the level of how many patients and how many days were people boarded in either the inpatient unit or the emergency room for a primary mental health diagnosis, substance use disorder, or a secondary mental health condition diagnosis, and by where they needed to go, nursing home, psychiatric facility, another hospital, and home health, and so forth. So we're going through that data now. And as I said, I'll review that with the hospital association. There was a prior consultant that estimated that 30% of emergency department visits were potentially preventable if good primary care and available community-based mental health services were there. The hospitals themselves ran similar data And those reports are quite similar, 30, 31%. I think the lowest was 28% for one of the hospitals. So, this is clearly being impacted by the lack of primary care, specialty care, and community mental health services. EDs are crowded, holding patients who need to be transferred to another hospital. One group reported 8 out of their 15 beds were used to board patients, so the emergency room stacks up. Another hospital reported 12, just opening 12 ED beds, and within 4 weeks, 8 of those were occupied by boarders. Observation beds also often used. And very, very importantly, for the emergency room staff, there are routinely delays in finding an inpatient bed for a patient. Patients are being transferred as far away as Portland, Maine, and New York City, and quite commonly to upstate New York, Albany, Springfield, Massachusetts, more and more to Connecticut and Boston, because there are not available inpatient beds that will meet the needs of those patients. And I've heard some physicians say, boy, I called 30 hospitals all over the Northeast to find a bed for my patient. It took me 6 hours. And then I had to spend another 4 hours calling 19 different ambulance services to find a group that could take the patient to that hospital. So the doc basically occupied most of his entire shift with trying to place a very sick patient in an appropriate hospital. I will note that we also heard a couple of stories about patients suffering what's called a STEMI, which is an acute myocardial infarction that requires, the national standard is 1 hour from when you're picked up until you're in a cardiac cath lab with a balloon dilated in your coronary artery. And we've heard a couple of reports of people being put in an ambulance and sent 5 hours away to have that procedure done.
Dr. Darren, we see a hand up.
Yes, I see. Sorry. Yes, please.
Oops, you're on mute.
Thank you, Robin. I'm sorry, not Robin. Susan. I am just curious with this data collected. Unfortunately, it's things that we've all heard many times. But do you know the length of time that these sort of bed shortages have existed? And on the flip side, has there been some sort of trend that's resulted in longer inpatient stays, resulting in less access to hospital beds because the lengthening of stay keeps creeping up?
Yeah, the honest answer is don't know. The comments have indicated this has been going on for a number of years, at least 3 to 5. And certainly some of the state agency reports or commissions that have looked at these things are 3 to 4 years old. So I think we could confidently say at least 3 to 4 years, and you with your local knowledge would probably be a better judge.
Thank you.
Yes, ma'am. Okay, so specialty coverage for emergency room patients is difficult, particularly in smaller hospitals. They don't have enough specialists. A number are using telehealth, but it is quite expensive and is not reimbursed. So the hospital will say, boy, I've got to deal with a tertiary center. They're charging me $600 per call, and I'm getting reimbursed 100 or 150. So it requires a lot of investment by the hospital. Now, we're hearing, some folks are using this for ICU coverage, which is very helpful. some others for things like neurology or cardiology help when a person comes to the ED. Next slide. Okay, prenatal care. We did not hear in any of the general public sessions that access to prenatal care was an issue. Elizabeth will comment on some of the inequitable issues with this. When I reviewed the data from the state Department of Vital Records, generally, I think you can say that prenatal care in Vermont is generally available, generally pretty well utilized, less well in women 20 years old and under. As Elizabeth will comment, prenatal and maternal care for diverse groups is difficult to access because there are small numbers of folk. But we have heard anecdotally that, as in the rest of the U.S., Black women in Vermont are more likely to experience preterm birth and have higher infant mortality rates than white women. It's also been said, and I think is true, that some rural areas in Vermont have very limited access to specialized maternal health care services, such as NICUs. These require, pediatricians and maternal fetal medicine people. There is some support in some areas with telehealth, but there is not a dedicated transport mechanism. UVM, I think, has one ambulance that's really outfitted for neonates. The other thing that was commented is that the high-level NICUs are really at UVM and at Dartmouth. And when you have to transfer a baby, that's quite a distance away from some people, and it makes it hard for mom and dad to get there and spend time with the baby. Next slide. Okay, transportation. We commented quickly about the ambulance services. There are roughly 69 different EMS services in Vermont. Almost all are volunteer. The emergency room people noted that 17% of local patients don't have a car. Another community member noted, boy, ambulance service is critically important, and there are not enough ambulances to go around, and so you wait. You may have seen an article in the New York Times a couple months ago that said, in a sense, having an emergency, the ambulance will be there in 45 minutes. Another problem is that a number of people cannot afford the gas to get to an appointment or to an appointment some distance away. We had one man comment that he had a family member who had a severe illness, required multiple visits over a year to one of the tertiary care centers, and that he reckoned he traveled 8,000 miles and spent $5,000 on food and lodging to get his family member to that care. So it can be quite expensive, and that, of course, is without considering the out-of-pocket costs for copays, deductibles, and so forth. Another thing we learned was that public transportation is often not available when it's needed, that shared rides, buses are usually only available during business hours. Bus routes in one town within the town did not connect with the buses that went longer distances to get to a tertiary care center. And the the emergency room people routinely said, gee, if we have somebody who is brought in by ambulance or by somebody else, police, a neighbor, and we take care of them and they're ready to go home, they have no transportation to go home. And the EMS folks are really paid only for trips that are, quote, medically necessary. So if you've been seen in the ED and you're taken care of, it's not medically necessary. Same thing applies if you go to a hospital out of state and you're discharged. How do you get home? Okay, we've talked about that. Next slide. Okay, diagnostic services. 6-month wait time for colonoscopy in a local area. Specialized diagnostics equipment is sometimes not available because the population in need of that is too small to really economically support the service. Several of the hospitals are addressing that by sharing equipment and the specialty people so that instead of going to hospital A, someone can go to hospital B 20 miles, 30 miles away. I've noted timely access to interventional cardiology is a problem, both for the acutely ill and for patients with unstable angina. That is angina that's getting worse and not controllable by medical means. And they've had waits of more than 3 days to just get to a place that has the capability to take care of that. Generally, throughout all the hospitals, including UVM and Dartmouth, there is a shortage of specialists. In the small hospitals, this means there are not people who can oversee a test, for example, a neurologic assessing the nerve function of somebody, or interpret the test. Some of the interpretation, of course, could be done by distance, and that is being done, for example, for some of the obstetrics ultrasounds. But there is also a shortage of technicians, and the technicians are leaving the state for better salary and are difficult to recruit, as we've talked about. In addition, many of these tests require pre-certification by an insurer, and we have heard stories where that pre-certification was time limited and it took the patient so long to get in to see the specialist that by the time they could, they had to be re-pre-certed. Next slide. Home care is not readily available. There certainly are very good home health services. They have had difficulty in recruiting nurses in part because of payment and pay scale. The amount they're paid does not allow them to pay the nurses a salary or a wage compatible with what's going on in the hospitals. And we've heard from a couple of the home health agencies that they have had to reduce services because they actually don't have the staff to do it. Next slide. Dentistry. You're well aware that access to dentists and dental providers is a problem statewide, even for those with insurance or money. And this is particularly a problem with Medicaid. The state did increase the reimbursement for dentists to see Medicaid patients, I think last July. We were still hearing comments in September and October and November that access was poor and that many dentists were not taking patients with Medicare. The state advocate's office felt that they were still hearing those stories, but they didn't have enough data following the implementation of the new pay scales to verify that. This is particularly a problem for children who are often on Medicaid. And the lack of preventive service is a cause of both emergency room visits and hospital admissions. And I would note, if you're not aware, that children who require substantial dental work require major general anesthesia to have that done. And that has a risk. Next slide. Robust referral structure to specialty and other care. Primary care physician said, I can't find specialists for my patients now. The referral system to get people into a specialist is broken. There are shortages of specialists at both UVM and Dartmouth. Results in long wait times. Usually they can meet an emergency need, but an urgent need or a routine visit will wait. And we're hearing stories of a year plus, similar to what we heard with the previous project on physician access 18 months ago. And we've noted in the past recruitment of medical specialists is a problem. I talked to the director of neurology at UVM. He said, boy, we've got over 30 neurologists, but we need another 25. Now, you know, the shortage of neurologists is so severe, that's not going to happen in 10 years. So alternate means of providing that care need to be found. One of the things that came out both 18 months ago and again is that because of the shortage of primary care, once the neurologist, let's say, takes care of somebody who has epilepsy or a severe headache, and they have a diagnosis, they have treatment, the patient's stable, they would normally go back to a primary care physician, but they can't. So they stay in the neurology clinic for a routine follow-up, you know, once a year, every 6 months, and that takes space away from seeing new patients. So that links very tightly to the availability of primary care practitioners, physicians, NPs, and so forth. Communication between hospitals and specialists to primary care providers was generally viewed as poor. VITAL, the State Health Information Exchange, is still under development. And the almost universal opinion was that it does not deliver accurate medication lists or a list of currently active diagnoses. And when you do an information exchange, and I've been party to one a number of years ago, you need three things. You need the current labs, which VITAL does do. You need the current medication list, and you need the current diagnoses. And we've got primary care folks that are talking about, I'm reviewing a 60-page report to pull out what I need. Hospitals and providers on many different EMRs depend on VITAL or similar HIE to connect with one another. Getting and making sense of specialist consultation notes is an issue. By the way, well, we'll get there. OneCare has not been considered to be timely in providing the information needed to specifically target patients for care. One hospital reported that it had taken 2 years for them to get a list of their dual eligible patients so they could target some specific services for that. And we've talked about the difficulty specialists have in referring patients back to the primary care doc. Next slide. Okay, cost. Universal issue. One person said people can't afford health insurance, so they don't get it. Healthcare costs, reasons cited, and of course, these are perceptions, not necessarily facts. High hospital costs, which clearly are there. Poor access to early treatment, who then present to the emergency room with more advanced and severe and therefore costly illnesses. The emergency medicine people were quite clear about that. A number of public comments said, gee, you know, I get an MRI or CT somewhere, I go somewhere else, they want to repeat it. Costs money. A perception that both hospitals and insurance companies have a for-profit motive and work on that basis. Hospital costs certainly being, as Vermont as elsewhere in the U.S., being driven by staffing costs, increased payments for all staff, nursing staff, housekeeping staff, and so forth. Certainly warranted. I mean, housekeeping staff, for example, often in the past paid less than they could be paid at McDonald's. Use of travelers, people from outside the state paid at very high rates to the agencies for both nurses and a variety of technicians. And at the hospitals, the use of locum tenens physicians, who are basically travelers, to staff certain vacancies, whether it's emergency room or general family practice or whatever. An increase in the costs of drugs and supplies. And a note that there's a federal program called 340B, which allowed hospitals to buy drugs at a lower price, add some cost or some addition to that, and thereby make a small margin. And in a number of instances, that margin was the income of the hospital. It's what kept them above zero. Next slide. Okay, Elizabeth, diverse populations and health equity.
Yes, thank you. And I think for those of you who I haven't met Elizabeth Sutherland, I recognize a lot of names here. Thank you for all the input that you've provided thus far, as Bruce said. One thing, there's a lot of words on the slide, I'll guide us through it. I think that the key message here is that we're leading with diverse populations, we did make sure we wanted to particularly target different populations across Vermont so that we had input from not just the average Vermonter, but from everyone experiencing the healthcare environment. And that health equity, our observations you'll see here, extend beyond just what the diverse populations that we typically associate with health equity might be, in that, race, ethnicity, gender. But particularly within Vermont, want to make sure that we're considering things like mental health, socioeconomic status, homelessness. Those are not things that are necessarily driven separately from health equity at large. So that's kind of the flavor of where the recommendations here or observations come from. So take you through the process on the left side here. These are the groups that we, as I mentioned, targeted to have specific interviews with, to ensure that we're getting input from each of them, either from them directly or from representatives on their behalf, speaking to the access and experience with the healthcare system within Vermont. We also heard a lot of kind of input around barriers, health equity barriers within our community meetings. And so it was it didn't take having these targeted discussions to unearth some of the observations that you'll see to the right. And as Bruce mentioned, just the left side, the list was originally, we started working with this list drafted off of who are the groups of focus within health equity grants for Vermont, and then kind of expanded it from there as we met more folks throughout our interview process. One of the things, and you'll see some quotes below, are I would say they're pretty direct quotes, and we chose these chose these specifically just to help kind of bolster what you'll see above in these observations. Obviously, we aren't attributing directly, but these are quotes that we heard throughout the process, and I think make the observations above a little bit more real. When we lead through the three main areas of observations are around culturally competent care for patients, culturally competent and psychologically safe work environments for those delivering healthcare, and then coordination across caregivers and community services, or areas of significant opportunity that we wanted to highlight as we think about solutions going forward. Before I dive in specifically here, just wanted to say there were some bright spots. And so one of the things that we wanted to, this focus and this report out is very focused on barriers and challenges to overcome as we think of redesigning the work, as we think of the goals for the future of Vermont's health systems. And so when I see the number 3 at the bottom here, the lack of coordination, just wanted to hit on that before we get into that, because there's a lot of services already out there that are being used and potentially duplicated because of that lack of coordination. So just before I dive into the areas of improvement, we did hear quite a bit of good stuff is coming out of Vermont for all the populations to the left. So to talk about 1 and 2 really specifically, I think, as Bruce mentioned, there is, when we were talking about prenatal care, there is real cultural gaps in culturally competent care that was noted by all the groups to the left, as well as through some of our community meetings. And the main areas that kind of oscillated around were language barriers, and so interpretation or translation services. Not that they don't exist, but that they're hard to find. And so the bills and communications coming out only in English without an option for without an option that's not written in English for how to find this in their language is difficult. And then the lack of kind of knowledge from some medical clinical staff of where to look for translation and interpretive services. Those are things that are provided. They are available. They must be provided by the hospital if you're taking Medicare, if you're being supported by Medicare or Medicaid funds. And so creating clarity is something that was noted as a challenge. Lack of clarity is noted as a challenge of where we should to get those services. Similar to, I think Bruce mentioned this too, as well as within the healthcare, within the emergency department, neurodivergent folks really feel kind of like they're being treated like they're taking advantage of the emergency department when they don't really know where else to go. So I think a quote we heard about that was, the hotel is not the hospital is not a hotel. And that was, I think, clearly stated by someone who was working at more of a physical emergency department perspective, but to someone who was in real dire need of mental health support. And so there is some not meeting the patient where they are based off of their needs. And we already noted the mental health crisis, but that's being exacerbated for patients when they come to the ED without knowledge of where else to go. The appreciation for cultural differences, I think that there's, an example of this is Afghan and Muslim women should be seen by women physicians. I think that's one example. There's a couple other examples of just the not really kind of aligning the symptoms that folks might be experiencing, like migrant workers coming in with flu or cough symptoms is likely due to them being, exposed to the elements. And not to continually come back with the same cough symptoms and not getting different treatments. So there's some examples of really where there could be some more culturally competent approaches to treating these populations. And then I think lastly, we heard for the LGBTQ population, particularly those who identify or who are gender fluid or identify as a gender other than birth, have some kind of have been really hitting some admin issues and barriers with physicians not feeling comfortable putting on paper some requirements needed to get housing requests that might be specific to the gender in which they're presenting as. In terms of internally, so we're thinking about culturally competent, psychologically safe work environment. Policies for zero tolerance toward hate towards workforce is not really known by the workforce that we spoke with. By those that, and some were raising some specific examples of how when they've been the victim of some hate speech, the reaction from management was to just send a different clinician to work with those patients. And so that, can be the process, but at the same time, that does sort of deflate the realities of what's happening and the abuse that's happening to the patient, to the clinician. And so there are lots of examples of how kind of these policies have been implemented in different hospitals, and just again, kind of like the language services make it more obvious and apparent what the implications are for hate speech and biased actions towards workforce. Goes a long way, and at this point, I think it's not very known to much of the workforce. And then I think that there's a lot of kind of action and that like forward progress that's being noted and desired in terms of racial equity. However, some of the language being used to kind of to support this kind of comes across as being almost kind of like judgment around people's tones. The ability to have discussions in a manner that is non-abrasive and non-confrontational has been used in written public documentation about people of color talking about things, which is something that's worth calling attention to, because that's, systemically, some systemically racist observations that we've seen. Lastly is the lack of coordination and with caregivers and community services. Patients with needs that are best served outside of the hospital are really driving up the ED utilization, as Bruce mentioned. And so figuring out how we can best tie together the resources that already exist and stay in step with each other could go a long way. There are resources that exist. Again, just the clinicians are not equipped to know where to kind of connect those dots. And then also similar to what Bruce had said, and you'll notice there's a lot of themes that are coming across here that are not just from the diverse populations, but just around the administrative resources required for patients in community health and nurse programs to access Medicaid is just a really daunting task. And so there's a lot of additional admin work that is that's creating barriers to equitable healthcare. All right, I know I just said a lot. Is there, before we move on, happy to take any questions or go deeper on any areas? Yes. Dr. McKee.
Hi, thanks for this this update. It's really terrific. I'm wondering if you can just take a minute and talk a little bit about the process that you've used to get from kind of what is likely thousands of comments into these kind of themes that you're presenting here, and then to use Bruce's words, how you move what is largely people's perceptions into some kind of connection to factual basis.
Yeah, sure. So the way that we did that here is, this is a typical, on the framework on the right side is a typical, I'll go from right to left. The framework on the right side is typical for healthcare and sort of kind of presenting the areas of opportunity. So when we're thinking about focusing on how we're treating our patients, how we're treating our workforce, and then how we're working with the surrounding environment to support removing barriers to equitable care. So that's kind of like the way in which we knew we were going to be conveying information and has landed in other, has been helpful in other, in our prior experience. To help us get information to then go underneath these three areas. The groups on the left side, as I mentioned, where we try to start, and again, health equity, try to live it, right? We're trying to meet folks where they are. So looking toward kind of like the true north for what has already been elevated as health equity needs for the state. And for us to get started on that list was to look at who has received, what grants have been created and given out to support which groups within Vermont. And so that started the group of diverse populations, and then we kind of collected a lot of more information throughout our interviews to say, people were like, you should talk to this person, you should talk to this person. And so that was kind of like a more of a webbed, like foundational start with what we know we're focused on, and then also add more resources in based off of what we hear in our discussions. Lastly, these themes that you see here that are specific to Vermont. So these bullets underneath 1, 2, and 3, these are very specific to what we heard in Vermont. And so what we did was take a lot of the commentary and look for quantitative data or information. So not necessarily a ton of data, right? So that idea about my public records of racial equity discussions, right? Like that is one specific example that we saw, but we would look for kind of like when we hear a bunch of trends around people's anecdotes, we'll look for either quantitative data that we can have to support it, which is basically where we've got across each of these. And then we'll look at the number of times people bring it up. And then we'll look at where we can find some substantial, either quantitative or qualitative support to highlight these as to prioritize these in terms of where we believe there's the most, where if you took an action against any of these, it would create a ripple impact for the state. I know that's not the most scientific. It's definitely not statistically significant. It can't be when we're talking about diverse populations, because that's kind of a chicken and the egg move, right? If you can only look at data that's statistically significant, but you don't have a population that hits that metric, then you're leaving them out. So we have to do what I just said to help kind of work your way through it. That's not one of the most typical kind of research, statistically significant based approaches.
Yeah, I appreciate that, Liz. Thank you. My question was also thinking more broadly about the entire presentation today, but I appreciate that was a great answer.
You can blow it up. I think Bruce, say if I got it wrong, but I think you could probably trickle that up to the whole system, and then that's how we got to it.
Yeah, I think, remember that we're trying to summarize what we've done so far. I mean, as I commented, we have reviewed a huge amount of data. Vital health statistics, demographic data, state data from VCURE and a number of other sources. And we are in the process now of analyzing a lot of that. We just got the 2022 hospital data. So we're using 2021, 2022 hospital discharge data, patient migration data, so forth and so on, the financial data from the most recent times to look at what, in a more quantitative way, what some of the problems are. Now, again, for health equity, we're not going to have quantitative data. I mean, the hospitals were only required starting January 1st to collect data on ethnicity, language, and so forth. And so that data set does not exist. So we're in the process now of analyzing the data that we have. That's going to take, we just got the most recent hospital data a week or two ago. So that's going to take a little time. We are formulating some options to fix some of these things and to help Vermont and Vermonters get some solutions to these things. And then those are going to have to be analyzed for their impacts on the financial state of the hospitals, the health of the community, access by a number of these different groups, and recognizing that I think Elizabeth may have commented, the most common sources of health inequity in Vermont are the rural nature of the population, the lack of access to internet, and transportation. And so a lot of it gets in effect to that last mile, right? You can get the stuff down a paved road. You can't necessarily get it up a gravel road or, in mud season. Could we go to the next slide or so? I think we're just about done, and I'm summarizing. Okay, I'm going to just skip this one. This is a lot of things and not the main purpose of this conversation. So here we are. We just got the 2022 hospital discharge data. We're only going to use the most recent data, 21 and 22, which unfortunately do overlap a little bit with COVID. We are working with another very good consulting group who is doing all the mathematical calculations. And we have gotten data on the numbers of dual eligible people getting both Medicare and Medicaid benefits because of disability and so forth. And in a number of instances, those are quite large numbers and would support some alternate ways of providing care. As I mentioned, we've just gotten the data from the Hospital Association that was submitted by each individual hospital in response to a set of requests on potentially avoidable ED visits and so forth. Some of you may have heard me comment that the hospital's calculation of this is about 30%. So it's about the same as a previous consultant estimated. We are currently looking at that in another way and looking at the rate of, quote, potentially avoidable inpatient admissions. We're looking at current shortfalls in care. What we're using for that is a rate of mammography and colonoscopy in the appropriate populations. You have some data from the Vital Statistics Department on prenatal care. So those three areas we can get reasonably good numbers on. We have been looking and will continue to look at the number of patients who are leaving Vermont for care that could be given in Vermont. So, as an example, if someone is going to a small hospital in New Hampshire, and some people are, those services for pneumonia or whatever could be done in Vermont. Somebody who goes to a community-sized hospital in another state could be cared for by a similar-sized hospital in Vermont as well. And those are dollars that are leaving, Vermont dollars leaving the state. They are also people who live in Vermont who are getting, in various ways, delays in care and increased travel for families. And part of our charge is to look forward 5 to 10 years and to try to predict what the impacts would be if certain things happened. I will tell you right now that there, based on what we've heard and the data, there are insufficient beds downstream of the hospital, mental health beds, nursing home beds, some rehab beds, certainly home health agencies that will be needed in order to offload the large number of people who are boarding in these hospitals, occupying beds that could be used for an acute care patient, and so forth. There is also, as I've noted, a huge problem with transportation. One of the real difficulties is that as services have been centralized at UVM, Dartmouth, one or two other places, physically getting patients from another hospital to those places in a timely way is a problem. And so, for example, there have been, I've talked to some emergency medicine providers who say, look, the system of volunteer services is 50 years old and it's outdated. It needs to be changed. Okay, so where we are then is we're putting the data together with these comments, formulating some potential solutions. We will test those solutions. I am currently in the process of physically going out to visit each hospital. So I've been to one. I've got another 5 or 6 lined up over the next several weeks, and we'll get the rest in. I am going to both Dartmouth and UVM. We're going to talk about these things and what the hospitals are trying to do, what some potential solutions might be. As we get these hypotheses tested for impact, then the plan, as Marissa said, in late spring, timeline slipped a little, but in late spring is to physically go back to each hospital service area, meet with the hospital leadership and board jointly, make a presentation of what the findings are, what the potential solutions are, and those impacts on the hospital and the community. And then to separately, either the day before or the day after, or that evening, make a community presentation, town hall style. Do not anticipate currently that the community meeting would have the same level of detail, particularly about potential solutions that would go to the board. We will then take the feedback from the hospital board and leadership and the community, reformulate those hypotheses and potential solutions, and then present that in a final report to the Green Mountain Care Board and the legislature and so forth. So we're, let's say, 60% through this process. We've got another 40% to go, another 28 meetings to do in the late spring. And we'll schedule those starting in another week or so when we have a much better feel for when these data analytics will be done. The timely availability of the data has been a little bit of a slowdown. I'm going to conclude by saying you have a very good group of healthcare professionals in Vermont. You have a very knowledgeable set of hospital leaders and concerned board members who are all working very diligently to take care of people in a very broken system. So I'll stop there. Ms. Hunt.
Thank you for this presentation. It's very, very informative. One thing that stood out to me, just with one of your questions being what stands out the most, and it's something I hear a lot as I work directly with independent physicians in Vermont, running Green Mountain Surgery Center, is the administrative burden that's experienced. And that's something that I personally have experienced. I'm 33 weeks pregnant, so I've been speaking to my various providers, just seeing what their experience is.
Right.
And then I also have a 22-month-old daughter who I brought into a physician's office for an ear infection on a Saturday. And I asked, I said, why are you here all day? Because he said, come whenever you want, I'm here all day. And I said, why are you here all day? Well, I have to submit my quality measures and I have to report on pediatric, the increased risk of pediatric hypertension. And I said, pediatric hypertension? And he said, this is what I have to do. And it doesn't make any sense. Why would I screen children for pediatric hypertension? This is not part of my normal clinical care. And the whole thing. And I've heard this type of thing. So I guess my question, and something that stands out the most to me, and my kind of question about the overall information you're gathering is, are you and have you been able to tie that to various ACOs, various quality measures, and what that is, whether it's benefiting Vermonters or in this whole Act 167's hospital sustainability, especially for the community engagement portion. Has there been any takeaway that maybe this is creating more of a burden and lack of access than it is increasing care to Vermonters?
Thank you for the question and the observation. Yeah, the answer is yes. As I commented on one of the earlier slides, this has been a huge problem for the docs and their staff. They've had to hire staff. They spend a lot of time. And I didn't emphasize, and I appreciate your bringing it up, the variety of reports that both the physicians and other providers and the hospitals have to fill out. And this, I think, is one those issues that is somewhat related to coordination. As we've talked to some of the state agencies, they are somewhat aware of this and have had a working group trying to get it organized. But the state currently does not, as I understand it, does not have a common data set into which all this is loaded and in which people don't have to re-enter data. So for example, simple demographic data, age, sex, residence, all that stuff, people have to re-enter for each of these reports. So yes, it's a problem. I think there are some solutions to it. I'm not, the difficulty is that many of the programs that are run so well in Vermont are federal grants, and they have individual requirements. And so, as I may have commented in the past, we're really looking at 3 sets of recommendations: one locally, one at a state level, and another at a national level. And I think some of these things around the national grants from Medicare, Medicaid, Department of Health and Human Service are going to have to be addressed by your congressional legislation or group. Let's see, Mr. Carpenter.
Hey, Bruce, I apologize in advance because I'm calling in from the front lines of Vermont's tourist industry at Mad River Glen and Facein, Vermont. And I got a bunch of background noise and skiers will be walking back and forth. One thing is, I was listening to the report. We have so much data. We all know about this.
Yeah.
And go on and on. It all boils down to the lack of money and to indifference. The lack of money, the minute we come up with a bill or the minute we try to do something about this, the legislature, state and federal, is probably going to say we can't afford it. And since the rich are sacrosanct in this country and the poor are not, we'll say we can't afford it, we can't tax businesses, which is another code word for taxing the rich. How are we going to address a lot of these things? My biggest worry is we're going to come up with a bill in the legislature and they're going to put it on the shelf and say, well, that's great, we can't afford it. So what? It's been going on, this has been going on for over 10 years, over 40 years. This is all the result of total indifference for anyone below the chief executive level. So just want to throw that out there. What can we do? Because, again, I don't see them doing anything.
Thank you. No, it's a real issue. And I think you see that when you look at a number of the prior reports that were well done and have not been acted on. And I think one of the things that that we are doing and have been asked to do is to build the case to the urgency of change. It's one of the reasons I mentioned that the lack of, let's say, the lack of hospital beds results in people having to leave the state to get medical care. And that takes your insurance dollars, your Medicaid dollars out of state. And it basically then cuts the number of dollars that are available to your hospitals and doctors and other people to sustain their activity. So that's one issue. I think the other is the documentation of the adverse health consequences to Vermonters and the fact that a good healthcare system is just as much of an infrastructure issue as electricity and sewers and roads when you try to bring industry in. so you're right. It is often, and not alone in Vermont, often an area which does not get enough attention or enough attention to financing. And I think the other area is that, yes, there are going to be some investments that are needed. The payoff of that comes over time. It's not immediate. It's like building a new road, right? You big upfront costs, and then the benefit comes over time. And I think, the ability to talk about that and show that is necessary. I mean, certainly, as all, the legislature has a lot of things to worry about. Rebuilding after the floods is probably a good example. Stop there. Mr. Dooley.
Thanks for an informative presentation. I think, as everyone said, these are not surprising issues for the most part. One thing that I have two totally unrelated questions. First one is when you talked about smaller hospitals doing televisits or teleconsults rather with tertiary care facilities. And maybe this is too granular for the data you collected, but are we talking about an in-state tertiary university that's charging $600 and they're getting reimbursed $150? Or are we talking about services outside of state in Texas or California or whatever? Because as we talk about hospital collaboration and hospital transformation, it seems like if it's the former, that seems to be an issue.
Well, some of it is certainly out of state, both to Dartmouth and people, I don't know, California, but Iowa. A little bit of it is to University of Vermont. And the other thing which has happened is that because of the shortages of various specialists at both the tertiary centers, quaternary centers, they have actually pulled back some of the specialists that used to travel out to the hospital physically. And so, that's another impact. Now, some of that we might be able to change with telehealth. But again, you've got to have somebody at the other end of that television screen. Right. So thank you for the question. But I think, the major issue, even anywhere, unless you're dealing with somebody in India, is that the cost, there is a cost for the equipment. It's not huge. But then there is the cost of having that physician at the other end available. And the carrying costs vary. I did mention we had one of the smaller critical access hospitals say $600 a crack. I do not know what that range is. One of the things I'll find out as I go see all the hospital folk is get a better sense of what the range is.
Right. And the other question I have, which is unrelated, around avoidable ED visits, because this has been a topic of discussion for the better part of a decade without a lot of solution. And, I'm a primary care provider. So frankly, yes, I realize that if my patients are seen here, that's better. We have lots of access in nighttime hours and weekend hours, and they still show up at the emergency room. I also understand the emergency room needs to see everyone who shows up at their door and can't say, oh no, that you're not appropriate. However, the problem with avoidable emergency room visits is they're expensive, right? You're taking up it's access, you're taking up a bed, and then they're there for 8 hours, and they get, honestly, everyone who goes in the ER gets imaging and an EKG, whether they need it or not, doesn't seem to matter. There used to be a sort of a fast track in most emergency rooms where they kind of funnel those folks off. Why does each emergency room visit have to be $1,000? Why can't the hospitals have an on-call provider who literally is there seeing the sore throats and billing $100 like I do here in the office and just see those folks quick? There's no imaging, there's no advanced, we're not putting an IV in. Why is that not part of the solution for these folks?
Well, it is, and some, to their credit, a number of the hospitals do that, right? They have, some are able to have a fast track in the ED. And a couple have tried that, but they're so overwhelmed now with the borders that they lost the space. Other hospitals have put up an urgent care center, And one of the things we've learned from conversation with those folks is, gee, if you have the urgent care center on the campus of the hospital, somebody drives in the door, they have a choice. Go right to the urgent care center, get seen quick, get seen much more cheaply, or go to the emergency room. A lot of them will go to the urgent care center. Unfortunately, and some hospitals have noted a decrease in their emergency room visits. Others have not seen that. And now, you know, it's a small enough sample. I don't know that we'll ever be able to show whether how much unmet demand that is because a provider left the community or something. But to your point, yes, people are trying that. That is another potential solution. It works. You know, another thing is that in some of the medium-sized towns, they have talked about, but have not yet done, putting one of those in downtown so that it's readily accessible to people. And I think there are some other solutions that that could work to reduce some of this load.
Great. Thank you.
Thank you, sir. Mr. Cabarino.
I think Kathy had her hand up before me.
I'm sorry, Kathy. Yep. I didn't see you down there.
There we go. Am I unmuted?
Yes, you're okay.
Okay, good. So just first of all, thank you. There's a lot of information to get to in this presentation, so I appreciate it was very well organized. When you went through the different topics, I heard a lot of things about things that are avoidable or operationally inefficient. Things like ineffective use of the ambulance, ineffective use of consultants and prior authorizations, and the pediatric hypertension. Why is that doctor spending time on a Saturday for something that seems quite uncommon, and those kinds of things. So when we talk about needing more primary care doctors, more clinicians, more space, more ambulances, do we have a sense as to where there may be opportunities to make sure that we can eliminate the inefficiencies before continuing to layer on more complexity to things? Yep. For example, I'll just share one example. I wrote about 10 of them because there's so many of them. But one example is in my current, one of my current roles, I interface a lot with EMS. And so I've learned a little bit about ambulances and billing and services and how they're used. And I'm not criticizing our local EMS, but I think it's, as you described, I think this is illustrative of how EMS works throughout the state and probably across the country. But a lot of times it appears to me that an ambulance is actually a taxi service or is a medical taxi service.
Yep.
So someone may have a minor issue, but they can't get to where they need to go to get the issue addressed. The ambulance provider doesn't know that, and they dispatch whatever crew is around, and it may be a paramedic crew. So then the paramedic crew is taking someone with a twisted ankle to, Springfield Hospital's emergency room. And now when the person in town has the heart attack and needs someone who is a paramedic, they're too busy at the hospital. So that creates delay in care, which you appropriately said it results in a transfer to Dartmouth that might have been able to be taken care of locally. And so it's just a snowball effect. And so I hope that we really, as we continue talking about these issues, that we look at our present state, because I think there's a zillion opportunities to remove efficiencies. I think that many of the public, and one of you mentioned this earlier, but I think many people in the public sector feel that all the care that is being provided is appropriate and necessary, and we just have a complicated system on how to deliver it. If we just fix that piece, and we get more people and we get more ambulances, for example, that we'll figure it all out.
Yeah. No, thank you. I mean, you're right on point, and couldn't agree more. I think, part of the, it's not always about more. It is about reconfiguring, maybe changing some resource, but unfortunately, there is some of the more that's needed. I, for example, talked
Yes.
to one of the heads of the mental health agency of the state, and she's trying to hire 1,000 mental health people. So
I
but
agree,
think,
that area, definitely.
but I think with regard to
Absolutely.
ambulances, for example, you have, 69 different groups that provide ambulance service. When I talked to a couple of the folk, one of the gentlemen said, I've been doing this 20 years. And he said, 10 years ago, I'd go, show up for my volunteer shift, and we might do 1 or 2 calls. He said that, several years back, for that group, we were doing 300 calls a year. Now we're doing over 2,000. And when I go in for night shift and, I've got to go to work at 9 the next day, I'm going to do 2 or 3 calls at night. I'm not going to get any sleep. And then I'm supposed to go put in a full day at work. So one of the things we've heard repetitively is that service needs to be professionalized. People need to be able to work at it as a job because there are costs involved. And it, I think, would be possible, and we, again, something to look at. It would be possible to combine some of those local services, use the support from the communities and the state and the hospital to really pay folks, and then do more of a centralized dispatch service. And I know that is a current discussion among the state groups, and they have, there was a very good state report 2 years ago, and it turns out ambulances can be dispatched by police departments, fire departments, whoever, and that needs to be regularized. I mean, the thing I was told was you call 911, the 911 folks are the ones that figure that out. Well, there's no 911 if you're in a hospital ED. Right.
Yes. So there's just, I was using the ambulance service as just an example. And, many people realize that if you go in by ambulance for your twisted ankle, you get seen sooner than if you were to drive yourself there or your neighbor was to drive yourself. Yeah. So that's then drives the cost up and takes care away from the people who need it. So thank you.
No, thank you. Sir.
I know we're at time, so I'll try to be quick. I've been a RN in Vermont for 15 years and was director of the undergraduate nursing program at UVM before I left about 8 months ago to work on a project to really bring diverse populations to pursue nursing professions, whether they have to go to get educated here in the US first or whether they have eligibility based on their education abroad. So working within Vermont and a lot of across the country on this. And I think one of the really big things that's unfortunately seemingly unique to Vermont and maybe New Hampshire and Maine as well is the biggest bottleneck for me is housing. Like these hospitals have needs, but their biggest concern in talking to me about bringing more nurses, even though they need, some cases 100 or more, is not having housing available to them. Right. So what are some potential solutions to that issue? And how can we kind of create the urgency around it? Because I think it's a really, really big issue.
No, it is. I mean, it's universal. And I commented on that. I think that the short-term solution, which nobody likes, in a sense, is probably FEMA housing, right? As a short term. What I've been given to understand is that if you come to the state and you want to buy land and build a house, you can generally do that in a year and a half. We had a conversation in a community, I may have been Brattleboro, where one of the folks on the call was the head of the local housing group. And what I think he said was that they had just gotten permission to build, I think it was 20 units of low-income housing, but it had taken 5 years to get through the environmental and all the other regulations. So one of the things that is probably going to come out is, folks, you need to relook at this, right? I mean, there was an article in the Washington Post several weeks ago about Houston, who had a huge housing issue for their their inequitable groups and the poor and so forth. And they had to change some of that. But as they did, they've now reduced that population by 67%. So I think you go a very short term, right? You don't put them up in a hotel, put them up in something that's, got a kitchen, got, something. And I know some cities, for example, not suitable probably for recruiting and retaining people, but there are places that have built micro housing, right? 120, 160 square feet, kitchenette, bathroom, bed and desk. And so there may be some ways to say to folks, look, we'll get you here, we'll have housing. And then as you get familiar with the area, you're on the payroll, we'll help you build. And I know that there are some hospitals in the state and elsewhere that will also support that. I'm on the board of a hospital in Bozeman, Montana, 120 beds, and we're doing that. We've worked with a local developer who's building the housing. We've guaranteed that we will guarantee the rents and bring people in as they then wait to find a permanent place that they can call their own. So I think there are some solutions, but you're exactly right. This is absolutely universal. And I'm sure Dr. Holmes would say it's true when they try to recruit faculty too. Any other questions or comments? Or certainly as you think of some, send them to Marissa or Susan and we'll get them. We really do want your advice and other comments. Mr. Carpenter.
Yeah, Bruce, you can just call me Walter and none of this Mr. stuff. Elizabeth mentioned about the prior authorizations and the bureaucratic red tape, and I just wanted to bring up a point that in 2015, the CARE Board did a study on prior authorization. Alan Ramsey headed it. I was part of that panel as a patient, and I was there to remind them that I had almost died from their prior authorizations, which is true. I was very, very, very close.
Mm.
We presented it to the legislature, and I was sitting in there, House and Senate Health Committees. And it was like, well, hey, great, thanks, so what? Bye-bye. So I wanted again to bring back that point that we've known all these problems for a while, long while. So what can we do? Because they're just going to ignore it. We don't have the money. It's the easy way. Because they know this. They know the prior authorization. They know the claim denials. We found the side at the end. Once we say, well, we need to do something, we don't have.
Yeah,
no. Then the hospitals will say, oh no, that costs too much, and so on and so forth. And CEOs are making it.
Yeah, as you think about it, you're already pre-certed and pre-auth, right? You can't get in to see somebody for 18 months, right? So from a strictly insurance point of view, you know,
That's
and
called
I don't know
rationing,
that
Bruce.
I
That's
don't know
rationing.
so, but no, I agree with your point. I think that the way, you know, we're going to try to go at it is to point out that this well, number one, it takes clinician time away from seeing patients. It's in terms of thinking about the provider workforce. If you take an 8-hour day and you're spending 1 to 2 hours on stuff you shouldn't have to do, you've cut the available clinician time by 1/4. Okay. And given the difficulty, the shortage nationally and all that, you want to maximize that physician time and you do not want to add costs. And if somebody, you know, has to hire 4 people for every doctor in order to handle all this stuff, you've increased costs. So it seems to me that we could build and hope to build and expect to build a case for urgent action. Now, again, you guys elect the legislature. Okay. So, you know, we'll bring it out and you know, try to do things that, number one, can have immediate impact. Number two, will have some intermediate and then the longer term. And I think, you know, just to point out, you all are considering, or the state is considering, changing the payment mechanism for the hospitals. So we're really going to focus, and that'll be in about 4 to 5 years. So we're really going to focus on the next 5. We will take into account changes in the population, the aging of the population, some population decreases as we look at necessary services. But, you know, I accept your point, Mr. Carpenter.
Walter's fine, Bruce.
We'll do our best.
Thank you, Walter. Just, I don't know if you've been following H766, Walter, just, that's in the House Healthcare Committee on prior auths. And I did, upon request, share that same study that you were a part of, the pilot with Dr. Ramsey that we did 2015, if that's correct. So thank you. Thank you, everybody, for your participation today. I know we're over, but it was a really robust conversation. Bruce, would you mind if I shared your email with the group just so they have that handy? And Elizabeth as well, if folks want to reach out to you directly with some feedback. I think this was so tremendously helpful. We have so many different types of clinicians and members of the public, and you know, this group is just so valuable to us. And with that, again, I know we're over, but we did put on our agenda several dates that we want to make sure you're aware of. I want to just highlight that we changed, thank you, Tara. We changed one date. We had to schedule a date for the hospital budget guidance. It was previously February 16th. We've changed it to February 21st, where our staff will be giving an overview of the hospital budget to the board. And you can see, I'll just rattle off, you know, the dates under the hospital budget guidance. So please, you know, we'll try to remind you with some emails, but we really do want your input if you have time to provide that to us. We're also receiving updates on the AHEAD model, which is a federal model, an all-payer model that CMMI has put out, and we're getting updates from our colleagues at the Agency of Human Services. The board is currently learning more about that model and evaluating that and getting more information, again, as I said, from AHS and others. So please take note of those dates. And if you can't be live, we have a YouTube channel, so you can watch these after the fact and reach out to us with any questions or comments. And then we start into insurance rate review. We get the rates in May, and then this summer we'll be having the hearings at the very lovely, right in smack dab in the middle of summer. So those also will be recorded if you can't attend them. Those are in July. So with that, I'll open it up to public comment or any other comments from the advisory. Again, recognizing we're well over time. Thank you for hanging with us on this. Okay, I don't hear any other comments. Our next meeting is June 10th. So we will see you then, and we'll follow up with emails for Bruce and for Elizabeth. And again, any other questions you have, just reach out to me directly. My email is right on our website. And we didn't officially start a meeting. I'm wondering if you want to, since there is a quorum here, Chair Foster, if you want to just officially close out the meeting. I don't know if we have to, since we didn't officially start a meeting.
Feeling, I don't think we need to officially end it, but thank you everyone for coming and attending and participating. I think we can just adjourn.
Sounds great. Thank you all.
Thank you.